the myths. Okay, so we are, as I said, looking at managing especially osteoarthritis. So today what we hope to cover is what is arthritis. We're going to debunk some of the myths around osteoarthritis, especially. We're going to look at breaking down the stages of osteoarthritis, and we're going to look at, why start a program, why do something different, or why change the way that you're what you're doing. We're going to go through a little bit of just basic dietary advice, some treatment, again focusing on non-surgical and conservative treatment here today, looking at your cardiovascular fitness, exercise rehabilitation, looking at the link between working on balance and proprioception, and especially with relationship to preventing falls, and looking at physiotherapy. So arthritis is an inflammation of the joints. There are several types of arthritis. OA is the most highly prevalent, and it can affect up to 10% of people aged 35 to 45 years of age, over 40% of adults 45 to 55 years of age, and rises rapidly with increasing age to affect 80% of adults over 75 years old. Obviously, this is a huge cost on the health system and quite distressing for many people. OA commonly affects the fingers, knees, and hips, and this is a result of the breakdown of joint cartilage and progressive structural changes that can occur after a joint injury or trauma, and symptoms include pain, redness, heat, swelling of the joints, and difficulty moving around. Rheumatoid arthritis is when the body's own defense system doesn't work properly. It occurs commonly in the hands and feet. That can affect all joints and bones. Its symptoms include pain, redness, heat, swelling of the joints, and difficulty moving around. It can also affect internal organs and can make people feel very sick, very tired, and fatigued. Other forms of arthritis, and there are many, but the most common might be ankylosing spondylitis, gout, and reactive arthritis. So moving on to the myths. So one of the things we commonly hear is, my mum and brother have arthritis, so I probably have it too. Although there is a large genetic link with arthritis, especially when we have the autoimmune forms, it's more often that osteoarthritis itself is a result of a previous trauma or activated by environmental or lifestyle choices, and body weight becomes a very big part of that. Arthritis is an old person's disease, and as I said, although many people in their older adulthood will develop some form of arthritis when they age, other forms such as rheumatoid arthritis can be an autoimmune problem, and they can begin at a juvenile age. Ankylosing spondylitis is quite often diagnosed when people are in their 20s to 40s, or even younger or older than that. And of course, we all know we could probably get gout if we don't look after our diet at any stage. This is one of my main pet peeves. So this one is if you run too much, you'll get arthritis in your knees. And that's something we commonly get asked. Oh, if they have a joint replacement, oh, it's because I think I ran too much. Or aren't you worried if you're running too much, you're going to get arthritis? Well, there's an increasing evidence to suggest that running may in fact reduce your chances of developing arthritis by increasing your joint cartilage and synovial fluid. The body responds to the load that gets put on it, and so long as it's not adverse biomechanical factors, really poor technique or alignment when you're running, if we can distribute that load evenly through the joint, there's no reason why it should cause problems. Recent studies as early as last year have shown that there's actually a reduced percentage of OA amongst marathon runners than in the general population itself. Another reason, I guess, as well that I think running is good, is any exercise that's going to promote a healthy lifestyle and body weight is also going to help to reduce your chances of getting developing arthritis. Next one, the only thing I can do is just sit and wait for a joint replacement. And with so much to be said about this one, but generally our focus is always on trying to prevent, delay, or even just prolong the need to undertake a joint replacement surgery. And a lot of people think that this is because if they get it done too early, then they're going to have to get a second one done. And although that might be true, that's not particularly the reason why we want to try to avoid it. There are many things that can be done to help prevent or delay and improve your outcomes pre and post-op. A recent trial called the Millwater trial, which was the management of osteoarthritis in New Zealand, found that exercise was the most cost-effective on the healthcare system and the most effective for long-term management of OA. Especially this was looking at the knee in particular, and that the use of manual therapy, such as what you would see a physiotherapist for, is quite cost effective, short and medium term, and effective, but not necessarily long term, and shouldn't be the sole treatment. Combining that with exercise is going to enhance the effectiveness of exercise therapy, and again, overall be more cost effective on the healthcare system, and give people a better outcome for their arthritis. Going on to the other thing is that if somebody has a diagnosis of arthritis, is that actually a quarter of those people will actually resolve, half will remain unchanged, and a quarter of the people will actually worsen. So it's about trying to think of what you can do to get yourself basically in the right area of those percentages. The focus should be on managing symptoms, maintaining mobility, keeping people active, productive, and independent. And there's a lot of biomechanical factors that we can also manage. So if we want to stop that adverse damage or load on the joint, then using things like orthotics, reducing body weight, strengthening, stretches, changing what sport, leisure, or even occupation you're doing can have a huge effect. And just overall, we should be looking at the general health of somebody and trying to provide the optimal environment for the body to metabolize and lay down new tissue. And last but not least, it's just a bit of normal wear and tear. So it's now accepted that osteoarthritis is a disease of the whole joint, and it's associated with, again, those adverse biomechanical forces. It's clear that OA is a complex and active disease process involving the bone, the cartilage, the synovium, the ligaments, and the muscles supporting and surrounding the affected joint. Again, it develops as a result of biomechanical insult to the cartilage and underlying bone, causing it to degenerate at a faster rate than the body is able to repair it. Focal stresses can be caused by congenital or acquired joint incongruity. So if the joint surface isn't symmetrical, isn't smooth, then that's going to cause problems further down the track. And one of those example is hip dysplasia. So that's when the hip joint doesn't develop fully when you're just an infant. And obviously normally they diagnose that and you get put in the double nappies or the splint to kind of help put the right pressure through the hip joint. And I see a lot of people coming through who are around about in their 50s now, who have got early arthritis in their hips because of sort of an undiagnosed hip dysplasia. Meniscal injuries and other things like ACL ruptures and surgery are pretty well known to result in the development of osteoarthritis in the knee. So then we're coming into the stages. So a lot of people will have early arthritis, but maybe not necessarily realize it. And so again, miss that opportunity to actually start to do some proactive strengthening or activity modification to help prevent them moving on to the further stages. So early arthritis, you might have discrete episodes of a very predictable sharp pain associated with a particular biomechanical stress. So this could be turning or bending movements during sports or work, or twisting as you get up out of a chair or out of a car. And although these are acutely painful, they're intermittent events, and they have relatively little effect on the function. So people can usually keep doing everything, keep playing the same sports, but they will eventually limit your involvement in high impact activity. Then we move on to stage 2, mild OA. So this is where the joint becomes more constant, or the pain becomes more constant, and it can start to affect your daily activities. The joint is often reported to feel stiff after periods of inactivity. So first thing in the morning or after prolonged sitting, getting up and feel stiff. The joint pain may become more unpredictable and may be accompanied by a locking sensation or feelings of giving way. And then stage 3, or advanced OA, is when that pain becomes more constant. You get a dull, aching in nature, and then very strong, intermittent, unpredictable episodes of intense pain. The unpredictable exacerbation of pain is very distressing and exhausting and results in significant functional limitations. So people often become a lot more limited in the activities that they can do and participate in. This is where people will generally be taking a lot more analgesic, pain medication, and anti-inflammatories. All right, so the why. So when it comes to starting regular exercise or changing your diet, and those are probably the kind of the 2 main things for sort of fighting arthritis. There isn't a magic pill, unfortunately. So I'm sorry if you signed up and expected some magic pill today. I don't have one. It's a long-term commitment, and this means changing routines, lifestyle, habits, and behaviors. It can be helpful to actually weigh up the benefits of changing those behaviors versus not changing and keeping things as they are. So looking at the diagram to the right, this is basically the cascade, or what I call sort of the downhill slide if it's OA left unmanaged. So what starts to happen is you limit your exercise, then you might start to gain weight. That can lead to metabolic syndromes or diabetes, cardiovascular disease, and then just overall poor health and outcome measures. On the other side, it's kind of your participation in social and work activities. That pain and disability leads to a loss of productivity. Again, that might result in having to change jobs or reduce work hours. And then again, an increased use of healthcare services, and again, a poor health and outcome overall. So I think trying to understand your why, and I'll just stop my screen share for a little bit. So understanding your why, why did you sign up today? You might be after information for yourself or for someone you know, or maybe you're a personal trainer and you work with people with arthritis. So that could be your why. You want to help other people. But if you're thinking about you personally, what is it? Do you want to keep playing with your grandchildren? Do you want to keep being able to tramp? Do you want to keep being able to work? Do you plan to go on an overseas travel? And you want to make sure that you can walk some great walks we've got planned, climb the stairs of some exhibit or anything. Planning for these things and really sticking to that why is the only thing that's going to ground you. If your main why is that you just want to feel less pain, that's not going to keep you committed to an exercise program or a diet, because as soon as that day that you don't have pain, you don't have that trigger to do your exercises again. It's about making it a routine, and that's the problem we have. People have no pain, so don't do the exercises, and they just end up kind of in this yo-yo roller coaster ride. So it has to be about a bigger picture and about your function more than your symptoms or your pain. I think as well, just again, making it part of that routine. So you might decide that you want to do certain exercises Monday, Wednesday, Friday, and just try to make that non-negotiable. If something comes up, think, okay, well, how can I still fit that in around it? Or having what we call like an if and then plan. So if it's raining and I can't go out for my bike ride, then I'm going to do A, B, or C instead. And just trying to make that plan foolproof, I think, is really important. So now we are going to go back to the screen. And I think it's really important to find a support network to help you on this journey. So let people know what you're trying to do. You know, if you want to be more active with grandchildren, for example, you know, tell your children, you know, what you want to do, and your husband or your wife, or, you know, that could be someone with sort of within your bubble or within your immediate family, or you could get the help of somebody outside, so a physio, maybe a personal trainer, maybe a life coach, maybe a nutritionist, finding someone that can help support you through that journey. And a lot of people find that this just might make them more accountable, just an external accountability. But again, I find a lot of the time people, you know, are often more passionate about doing something for someone else, for their kids, or for their husband, or their wife, or for somebody that they love, more than for themselves. So I think ultimately try to think about why it matters to you, and what it means for your health and stuff as well, and get the right support behind you. And so that, again, that keeps that accountability, so that you don't fail and nobody knows about it, so it doesn't matter. If other people are counting on you, then I think it makes a big difference. Again, I'm no nutritionist or dietitian, so I won't spend a lot of time on diet, but why is weight most important? Well, it's the biggest link between diet and arthritis is your body weight. So being overweight, and the way that joints work, it puts a great deal extra burden on the weight-bearing joints, including mostly your back, hips, knees, ankles, and feet. If they're already damaged or under strain, then this is going to be more detrimental. On the other hand, you might have somebody with rheumatoid arthritis, and because of this being very different, they may struggle to actually maintain a healthy weight, and actually have to take in very small but frequent meals to help avoid undesirable weight loss, which might affect their bone density and muscle strength, and increase your intake of food high in healthy fats, and also, you know, so things like oily fish, avocados, nuts, olive oil. You know, should aim to reduce the amount of fat, salt, and sugar you eat and drink. Obviously, just these are things that just sodium levels, unnecessary weight gain. Things that should be included in any healthy diet: whole grain breads and cereals, vegetables and fruit, milk and milk products, lean meat, poultry, fish, and eggs. Some people may benefit from restricted diets, so excluding wheat or dairy or meat, for example. And I don't think this should just be done lightly. I think it's best to do this under supervision of a nutritionist or doctor or dietitian, just to avoid depleting yourself of vital proteins, carbohydrates, and nutrients that your body needs. So making sure, if you're going to cut out meat, that you're providing it with adequate non-meat forms of protein to sustain your muscle strength, as an example. The Ministry of Health recommends that we eat at least 5 portions of fruit and veggies every day. The more colourful these are, the better, because they'll be higher in antioxidants and vitamins. And we should aim to eat oily fish such as kahawai, tuna, salmon, sardines, herring, mackerel at least twice a week. The current evidence suggests that omega-3 fatty acids found in oily fish are likely to be beneficial if you have inflammatory type arthritis. Now, this has probably got the strongest evidence out of all supplementation. Alternatives such as glucosamine, chondroitin, turmeric, which is the curcumin, vitamin D. There's some evidence out there. It's conflicting evidence because a lot of the times the studies are funded by the companies that produce those vitamins. So I guess it has to be taken by case by case. And my general rule of thumb is that if you are taking something like that and you're not really seeing any change in your symptoms after that course of 6 weeks, then again may not be doing any benefit. But a lot of things like glucosamine and chondroitin, the aim for them is to help attract basically more fluid into the joint, which bumps up the synovial fluid, which is basically the internal lubricant of the joint, and also helps to get the cartilage to attract more water, because the way that the cartilage works is that as the cartilage gets compressed, and being that it stores water, as it gets compressed, the water gets squeezed out of it, creating a sort of slight film that the bony surfaces and the cartilage can glide over. And of course, if the joints are very dehydrated, then you end up compressing onto onto the cartilage more than gliding. So imagine like an ice skater going over a nice smooth bit of ice, and slowly that friction is melting the ice and they glide nicely, versus that if they just come onto a hunk of gravel and then they start to lose that momentum and become very dull in their blades, I imagine. So general treatment for arthritis is usually more towards your mild to later stages is medication. And again, if you have an acute flare-up, so know that even mild arthritis might go through phases of having a kind of reactive flare-up. Say if you did too much activity one day. So anti-inflammatories also can be very effective. Oh, I knew that had the escalator somewhere. Anti-inflammatories can be effective for short term, and usually this might just require you to take them for a week to settle things down, and then backing off to nothing, and then obviously get pain relief. And a lot of people, this is where they, in those early stages, like to go with a natural form of anti-inflammatory like turmeric, just for the overall health, rather than it's really not going to be that effective in an acute flare-up. Then we've got your exercise rehabilitation, so we'll get to a lot of this later. Physiotherapy, which again we'll cover later. Hot and cold therapy, so again these can have a large effect on the pain receptors around the joint, but also may help to manage swelling if you're using hot and cold. And a lot of, again, it comes down to personal preference with a lot of people. Some people love heat because it helps to free things up and get their movement going, and other people love cold because they feel it reduces their swelling and it helps to relieve pain. So everyone has their preference. So sometimes it depends what season it is. And then we have surgery, which again should be the last sort of resort, but that could just be arthroscopic to repair some damage, and that might help carry somebody on quite happily for many more years. And then you've also got joint replacements, and the aim of those is really to relieve pain. And so nobody will have a joint replacement surgery until the point that their pain is becoming quite unbearable. So when it comes to exercise rehabilitation, the main components that we look at are the cardiovascular fitness, strengthening, stretching, and balance. So starting with the cardiovascular fitness, and I mean, as a general recommendation, everyone should be doing 2.5 hours of moderate to high intensity exercise every day for their general health. That's it. But When you're doing a strengthening program, we should begin each session with a warm-up of 10 minutes, either walking or on a treadmill or exercise, or if you don't have either of those things and you can't walk great distance, then on the spot marching can be fine. So you might just put a mark on the wall between your knee and your pelvis height and make sure that you can raise your knees up to that height, and you could do that holding onto a chair if you needed to as well. Cycling is fantastic, and any surgeon would probably tell you if you ask what's the number one thing I could do for my knee pre or post surgery or to prevent arthritis, anything, they would probably say cycling. Cycling works so many muscle groups around the joint, which is fantastic. It's non-loading on the joint, and it's an internal massage for your knee. So it really helps to get that blood flow and that synovial fluid within the joint moving and help to keep the joint as a whole moving. Electric bikes, I love the rise of electric bikes. So great for your mental health, getting out there on an actual bicycle. Helps you obviously so you don't have to strain too hard getting up the hills, and they offer that assistance. So I would definitely recommend looking into electric bikes. Aquatic therapy can also be very beneficial, but it's important to also include land-based exercise, because aquatic therapy doesn't necessarily put the stress on the bones that we need to encourage growth of new bones, especially for prevention of osteoporosis. But also, you've got to watch out in the pool, cyclic movements with the legs that might be like treading water. It may be quite disturbing on a knee joint that's not stable. So best to do kind of linear movement, and obviously do it for the benefit of the cardiovascular system. And swimming obviously can be fine as well. Walking and running, again, is really based on the individual and the stage that you might be with your arthritis. But as I said, running, actually the studies that they looked at whether running is safe, many of the people in those studies had meniscal defects or cartilage damage and benefited from training for a marathon. So you don't have to rule it out at this stage. It's just important to progress a program very slowly, maybe get the help of a coach for that. And Nordic walking poles are fantastic, especially if you're doing a lot of tramping. They can, I think, reduce it by about 20%, or I can't remember the exact number, but they can significantly reduce the load on your knees when you're walking up and down hills and stairs, and also can help to assist you with your balance if you're on trails, crossing streams, or on unstable surfaces. So as well as the fact that if you're just walking them on the street and you're pumping the arms and the legs, you're going to get a much bigger cardiovascular workout as well. Just important to know though, if you do have a history of cardiovascular disease, just to obviously consult your doctor before undertaking an exercise program. And again, talking to a physio might be wise as well. So we're just over halfway, we're getting into the fun stuff here. So strengthening exercises, and I can send, we are recording this and we can send, I'm going to figure out how, a copy of the PowerPoint to people so that they've got a few of these exercises to do if they're so inclined. But strengthening, now a lot of these exercises are based off that MOA trial that was done. And each exercise, there's usually 3 levels. On the trial, they had 3 levels for each exercise. So if there is an exercise that you can't do, there is bound to be an alternative that you can do, and then you can progress through the levels. But I've put the levels that I think would be most appropriate for many people and most beneficial. So strengthening exercises are performed in 3 sets of 10 repetitions with a 3-second hold. And you should not be experiencing pain of more than a 2 out of 10, and if so, then the easier level should be found and done instead. And my recommendations would generally be to be doing strengthening at least 3 times a week. But most of these exercises are quite safe to do every day without causing overload. So we've got the side lying hip abduction. So that's working on your glute muscles, side of your hip, very important for stability in your hips and your knees. Glute max going, and also your hamstrings going into your glute bridge. The clamshell exercise, which also helps with your hip rotators and glutes. And then the isometric wall squat. So this on your wall squat to 20 degrees. So it's a range that's used quite regularly when you're walking up and down stairs. So it's quite functional. And then we've got your calf strengthening. So, you know, this is off a step, a little bit of extra stretch, but it can be just done on the floor and holding onto a chair or the wall. And then deep abdominals. So this one is just a heel slide exercise where the aim is to try to keep the lower back in a neutral position, activate the abdominal muscles as you slide one leg out along the floor. And other alternatives might just be lifting one foot with the knee bent, lifting one foot a couple of inches off the floor and trying to activate the abdominals to prevent that. And again, many people might be well beyond this level and this could be quite easy for them. So there's plenty of more challenging abdominal exercises that can be done. And then looking at stretching. So stretching is obviously a really important part of the program because again, it helps to stop that imbalance around the joint that might put stress in certain areas of the joint and helps you look at improving the overall flexibility across the joints and the muscles. And stretches should be done for a total of 2 minutes on each stretch. And those should be 2 stretches of a 20 to 60 second hold. So this one is a hip flexor stretch. So this is a really nice one because a lot of people, again, if they've got problems with their knee, may not be comfortable kneeling on the ground. So you could just use your bed and sit on the edge of your bed, hug one thigh towards you and tip back. And so it's just stretching through the front of your hip. And really good if you're doing a lot of sitting, if you've got a very sedentary job or you're doing a lot of driving, really important. Then we've got the seated hamstring stretch. And again, this could be done with standing with your leg up on a step. But this is stretching out through the back of your knee and your back of your hip as well. And then we've got the faded stretch. So this is just looking at some lateral rotation of your hip and stretching out through your inner thigh. And then the glute stretch, which is also known as the pretzel stretch, which can be done either sitting or lying down with your foot crossed over your opposite knee. ITB stretches, again, can be done in standing or kneeling, and also it's obviously going to stretch the trunk side flexors, which is similar to the exercise directly below that, which is in a sitting position. And then your calf stretches. So again, this might be just, at the moment, this one's demonstrating the long calf stretch, your gastroc muscle with the knee straight. That can also be done with a bent knee, so you're stretching the lower calf muscle as well. And then in the one in the bottom right hand side, that's stretching your hip again, but also stretching your quadricep muscle. And again, this one people find quite challenging sometimes because they are very stiff through the knee joint if they've got more advanced OA. And so it's always important to make sure that you swing your leg from the outside up onto the chair so that you don't spend too long trying to get your foot up onto the chair and end up cramping in your hamstring. That is a very important stretch for keeping the knee flexibility going. And then some general trunk stretches, so hip rolls are great for that. I really love doing just your hip extension stretch up on a chair because you also get a bit of a stretch in your knee, but really open up through the front of your hip and your thigh at the same time. And then inner thigh stretches, again, depending on how comfortable one is, go with that sort of side lunge position. And then we come to balance. So balance is something that's really often missed out in programs, but really important. So what is balance? Balance and postural control is the act of maintaining a state of balance during any position or activity. And proprioception, it's a bit of a fancy term that I suppose it is like to use, but that is your perception or awareness of the position and movement of your body. So that's just knowing where you are in space. So chronic conditions such as arthritis are associated with a higher risk of falls. Arthritis negatively affects the structure and function of the muscle integrity and sensory functions, which in turn is likely to influence balance and compromise the safe performance of daily activities. And it's really important that exercise programs include 2 or more elements. So looking at strength and flexibility, or strength and balance, or flexibility and balance, are shown to have a greater effect on reducing falls. Other factors to consider when it comes to fall prevention are visual impairments. So there have been studies that have shown that if people have cataracts and they have cataract surgery, then that obviously will reduce their falls through having clearer vision. And in terms of medication, so blood pressure control, other drug interactions, if you're coming off psychotropic medications, then which are usually antidepressant type medications, then this can really affect somebody's state of mind, and that can also cause falls. But generally, there's been a lot of studies, and Joanna did a great deal of footwork in this. I'd love to have included it all, that people with arthritis have a reduced ability to detect and control their postural sway. So postural sway is if you're standing and you basically with a straight body lean as far forward as you can without bending at your waist, without losing balance, and you sway backward as far as you can. So and then side to side as well. So people with arthritis often have a much reduced range for that and hold themselves a lot more rigidly. And that's, just like seeing a tennis player who's just frozen like a statue, has the ability to react to changes in their environment starts to become a lot more reduced. And so that's what we try to aim through doing balance exercises, and improve that ability to sway within an area of control, within a range, or basically within your safe box, as it were. And as you get more confident, that box starts to extend and you can move out in bigger ranges without losing your balance. But the deficits in muscle strength and proprioception secondary to arthritis can result in that impaired balance. And a particularly widespread pain has shown in studies to be a substantial risk factor for falls, with a 60% increased risk of falls for women who had significant symptoms of arthritis and other musculo-skeletal disorders. So it's really something that it shouldn't be overlooked. But where a lot of people go wrong with balance and what they don't like about their balance is that they often start at a level that's far too challenging for them, lose confidence, don't feel safe, and stop balancing exercises. So making sure that you get the formula right when you start. So start at a level that provides some challenge, but is actually achievable. And you create a safe environment around you. You stand next to a wall or a bench top that you can hold on to if you need to. Learn to discover what that range of your postural sway is, and practice that postural swaying, just standing and leaning forward, leaning backward and side to side, like you're being blown by a strong gust of wind. And just practice it with your eyes closed as well. And again, feel your breathing. So a really nice thing to do is just to stand and just breathe in through your nose and out through your mouth, and just feel how your body naturally sways with that breath. And what should happen is that when you breathe in, you naturally come forward, and as you breathe out, you naturally sink back, and that's a normal amount of sway in the body. So have a little try of that for yourself and see how it feels. But practicing a bit of weight shift from one foot to the other is important, and making sure that you can do that without having to lean your shoulders off to the side. So imagine you're balancing a plate on top of your head, or a book on top of your head, when you do it, to try to keep your head even and your shoulders and your hips aligned. And then try narrowing your stance or your basic support. So practicing with your feet quite close together. Obviously, when we see people standing and their feet are very wide apart, it often shows that they have reduced ability to balance and have trouble with that weight shift. So their walking is going to be affected as well. So practicing bringing your legs closer together and then again closing your eyes. Then you can also practice with one foot in front of the other. And if one foot directly in front of the other is too difficult, then just take them a little bit apart and start edging your way together until you can hold your balance. And when you're doing balance, again, it's not about being a statue. You don't have to stay still and absolutely rigid. Keep your hips and your knees and your ankles soft and allow yourself to balance, to recover your balance, rather than staying rigid where you have no ability to respond. And you end up having to lean with your upper body, which is a bit like oversteering a car and often actually throws you off balance. So some examples of balance, we can see here the weight shifting, the narrow stance, single leg stance, tandem walking, backward walking is great. Then if you're okay on single leg, then adding in a proprioceptive challenge like standing on a pillow or a cushion or a foam mat, you know, even things like standing on carpet versus a hard floor, standing on a Pilates mat can add greater challenge. And then adding in things like the grapevine walk, so crossing one foot over the other, because a lot of people fall when their legs get tangled up in each other. So really confidence with crossing over the midline of your body is really helpful. And then just putting some obstacles on the ground. I've got young kids, so I have constantly got obstacles to walk over. I've had a few collisions with Lego today, though, unfortunately, so I don't know what went wrong there, but putting a few obstacles that you can step over or step sideways. And the biggest challenge with these is, again, if people don't have a lot of confidence on one leg, when you're stepping over something, you do have to hold your balance on one leg for longer. So just make sure that you are comfortable in single leg balance before you add in obstacles. And then we've got physiotherapy. So physiotherapy, well, I definitely learned through doing telehealth over the last 3-4 weeks, is that actually we, 80% of what we do isn't actually putting our hands on people. So we do offer a lot of advice, education, and we also, write exercise programs for people as well. But what we do when we put our hands on people is that we try to optimize joint mobility through manual therapy, which is manual therapy just refers to either mobilizations or manipulations of a joint. And those go through grades. So we don't just click and crack things, we grade it and we start with lighter grades first. And if they aren't effective, then we progress. So what you're seeing in that picture is an example of a hip joint mobilization, where they're providing a little bit of traction to the hip joint, which is allowing the hip to move through a greater range of movement and stretch some of the joint capsule. And these techniques should be pain-free most of the time. Obviously, we do some soft tissue techniques and some deep tissue massage and trigger point release. And this can help with the extensibility of certain muscles or connective tissues or the joint capsule. And then other treatments that physios may provide, such as acupuncture or electrotherapy and massage, are really just to help reduce that short-term pain of an acute flare-up. And again, it's not a standalone treatment that should be coupled with exercise therapy long-term. But what we find as well is that people might need a bit of a tune-up every now and again. So it's much like taking your car to the mechanics. So just because you might need to come and see a physio once a year or a couple of times a year doesn't mean that you're not on the right track. It just means that you're just helping to make sure that you're taking away any joint restrictions that is going to put adverse load on the joint if it's not moving through its full range of movement. So it's just like changing the oil and giving things a bit of a spruce up and making sure that everything's running smoothly. And so the best management with physiotherapy might be when we first see someone, we might need up to half a dozen treatments. Might be less, might be more. And then we might look at trying to follow up with them maybe 3 months down the track or 6 months down the track. Then people might often see us every year or every other year for, again, a bit of a